Good morning, my future consultants. Now we will continue the chiasmal and the optic nerve disorders according to its anatomy. Last session, it was the example of how you deal with this lesion, how you can diagnose it, how can the optic nerve or the optic tract or the chiasma can be affected according to the anatomy of the lesion. Okay, so we have discussed the pituitary adenoma as an example. So, what's next? The craniopharyngioma. From its name, what can you detect? Actually, pharyngioma from the pharynx, then cranium from cranium. So, it's something extending from the pharynx to intracranially, and this is actually how it is. Actually, it's like an opening in the upper, in the roof of the mouth, and the upper wall of the mouth, that extending towards the anterior pituitary gland. Okay, so it's formed embryologically and it is supposed to be closed. So if you have still a remnant of this Rusk's pouch, the pathway, then you have a craniopharyngioma. So you are having a tumor that is slowly growing from this remnant. Okay, and how your patient will present to you actually according to this age, because this tumor is compressing the pituitary gland, affecting the hormone. So if he's still child, you will observe the hypothalamic function that leads to dwarfism and impaired sexual development. But in adult, actually he has already grown up, so the growth hormone won't affect him that much, but it will affect the chiasma through the visual acuity and visual defect. Okay, so how can we investigate it? It's an intracranial tumor, so sure, with MRI and CT. And the treatment is the surgical removal of this tumor. Okay? In paracellular meningioma, just want you to know that the meninges here, as if it is surrounding the optic nerve just from the inferior. And I'll tell you when we will use this tip. Just keep it in your mind. Okay? So the paracellular meningioma, obviously, it's from the meninges that's around the sella turcica. It is somehow like the pituitary adenoma because it produces chiasmal compression mostly during pregnancy. The presentation of the tumor according to its site, and it has three sites. According to this site, it will affect the chiasm or the nerve. The first site, the trabeculum celli, it affects or compresses the junction of the chiasma of the optic nerve. So can you recognize that we said here nerve, not tract, so it is at the anterior part of the chiasma. So the nerve which carries the nasal and the temporal fibers of the ipsilateral eye, and the chiasma which contain only the nasal fiber from the other contralateral that's crossing through the chiasma. So what it will give us? It will give us ipsilateral central scotoma because it compresses the whole nerve, and the contralateral only compression for the nasal fiber, so affect the contralateral temporal defect. And actually it's the upper temporal. Why? Because it is compressing from downward, so the lower fiber are affected, obscuring the upper temporal quadrant. Okay, this is the first site. The second location or site of the tumor at the sphenoidal ridge. Okay, and actually it is characterized with proptosis and hyperostosis. Why? Because they are mostly in the sphenoid bone and in middle cranial fossa. Okay, so this tumor will end up in enlarged and enlarged till they push the eye and causes proptosis and reactive hyperostosis. Okay, olfactory groove meningioma. From its name, olfactory, it's about the smell. So it is accompanied by loss of the sense of smell and also optic nerve compression. But we need to know what is special about each side so we can diagnose it. So if you have a smell affection, so it should be olfactory one. If you have a proptosis and hyperostosis, so it's sphenoidal ridge. If it acts on the chiasma and the optic nerve, so this is a trabeculum celli. Okay. Another type is the internal carotid aneurysm. Actually, internal carotid artery, it is passing not below the chiasma, it is beside the chiasma, not like the previous examples. So when there is aneurysm and enlargement in size and the compression, it will push the chiasma from its side. So which fiber which will be affected? Sure, the temporal fibers, because the nasal fiber are inside the chiasma, they won't be affected early. So mainly it is about the temporal fibers that will be affected. And actually, according to which side is affected, which internal carotid artery, so it may cause asymmetric chiasmal syndrome. It's not typical the bitemporal. Okay, this is the internal carotid. Another type is the chiasmal glioma, and actually, chiasmal glioma, it's more commonly you will see in children. How can we detect it? Detect it by actually its effect on the optic chiasma, but not limited to the crossing fiber. It will cause decreased in the central acuity. It's not just the field, okay? And it possibly worse in the temporal field, but often more diffuse. That's why we detect it by age and by decrease in the central acuity. And rarely the chiasmal lesion decrease the central acuity. Actually, this often comes at a later stage.